Okay, thanks. Welcome to this PANACEA webinar on cybersecurity and COVID-19, experiences from the frontline. We're here today looking at the increasing cyber threats targeting the healthcare sector during the pandemic and looking at ways to solve those problems, whether they be through implementing best practices and guidelines or coming up with new solutions that can fit sort of this expanding landscape. I'm here this morning co-chairing this webinar with Pasquale Mario from the Gemelli University Hospital in Rome, and I'll let him now introduce our panelists. Thank you, Pasquale.
Thank you, Stephanie. Our panelists include Sabina Magalini. Sabina Magalini is a surgeon, and she works at the Policlinico Gemelli and is the project coordinator of the PANACEA project. Matteo Merialdo is an engineer working for REA Group, which is an engineering company dealing with cybersecurity PANACEA project. Kalia is an engineer too, and she is a senior researcher in cybersecurity and works in the R&D and planning department of the 7th Health Region of Crete. Stephanie,
so
please.
Thank you. Yes, we have some frontline people on board from the medical and healthcare profession this morning. I think this gives us some unique insights into the landscape. If we can just show quickly the agenda for the day on the next slide. Okay, so we're just giving this brief introduction, and then we're going to launch our first poll. Actually, we're going to launch 2 polls, one after the other. I will read out the questions for you, and you have a few minutes to choose the answer you think fits best in your opinion. And then we'll be moving on to the experiences of Sabina Magalini and her team, and the research that she's been doing into the threat landscape during COVID-19. Then we will get insights into a broader picture, looking at cybersecurity and privacy in a healthcare region, which is in this case Crete, and the digitization of healthcare. And then Matteo will talk us through the PANACEA toolkit in the context of COVID-19. It will end each of the presentations with 1 question per panelist, and then we will move on to the interactive session. You can post your questions anytime during this webinar in the Q&A window, which may appear at the bottom or the top of your screen, and you can do this anytime. If you have any comments, you can use the chat, but please post any questions and indicate if they are for a specific person into the Q&A window. Okay, thank you very much. I think we're ready to launch our first poll, so I'll pass Andrea to my colleague from Trust IT. So I think we can move with the first poll now, which you should see appearing on your screen. So the first question is, to which of our stakeholder types do you belong? Is it research and academia? Are you part of the healthcare provider landscape? Are you a policy maker? Are you just an IT specialist, not necessarily working in healthcare? Are you a provider or developer of medical devices? Or do you belong to another of these stakeholder categories? So we'll just give you a couple of minutes now to answer that question, and we'll share the results live, and then we'll move on to our second poll. Andrea, perhaps you can tell us the status of the poll responses as we do it. Yep.
Hello, Stephanie. Yeah.
Yeah. Yeah. Go ahead, Andrea. You have the floor, yours.
So we have the 30% of people coming from the IT sector. We have policymakers as well, people that work in the medical devices domain. Then we have another a good chunk of people that choose other as an answer, so they are not better defined. But yeah,
how many
no
participants?
research.
Yeah, no one from research. Okay.
No, and neither from the healthcare provider sector.
Okay, so can we perhaps share the results live?
Yeah.
We're not voting, by the way. No, none of the hosts or panelists have voted.
No.
Yeah, so that's
okay.
Okay.
So we are sharing the results now.
Okay, so there's a lot of others, and it's on at the same level as people coming from the IT sector. But yeah, okay, fine.
Yes.
Thank you very much, everyone, for voting. I think we can close this, Andrea, and then we'll launch our next poll. And before we zoom into the actual issues and challenges. So this next question is, in your opinion, what are the main barriers to better cybersecurity in hospitals? Is it lack of staff awareness, especially medical staff? Is it a lack of adequate IT solutions? Or is it a lack of risk governance across the organization? Of course, all of these are important, but we want to know your personal opinion in which, for you, is the greatest barrier to improving cybersecurity in the healthcare sector. And this is one of our discussion points, obviously, this morning. So we'll just give you a couple of minutes to reply, and then Andrea will share the results.
Well, actually, Stephanie, lots of people are voting for the lack of risk governance across the organization.
Oh, very interesting, yes.
More than 70% of our attendees.
Wow, okay. Let's just show those results then live on the screen. This doesn't appear, we are recording the webinar, by the way, and that will be available after the webinar, along with the presentations, but you don't actually see these polls in the recording, but we will share with you the results through a set of graphs, so afterwards. So,
I'm closing the poll, Stephanie.
Okay, lovely, thank you.
As you can see, the 78% of people voted for lack of risk of governance across the organization.
Oh, that's food for thought, isn't it? Yeah, okay.
Yeah, it is.
Yeah, okay, lovely. That's something we can perhaps come back to in the interactive discussion later on this morning. Remember, any questions you have at any time, please post them in the Q&A. And any questions that we don't answer, we will save and we will discuss internally and also include this in, these additional answers on our website. So that's PANACEA, www.panacearesearch.eu. You can just show the last slide quickly before we move on to Sabina. So, here is just a quick teaser. This is a brand new image from ANISA on the increasing threat landscape during COVID-19. As you can see, there are lots of threats and vulnerabilities that have come to light, even more, which COVID has actually highlighted. So we're obviously talking today just about what it means for the healthcare sector. And if you could just turn to the very last slide, Andrea.
Sorry, Steph?
Yeah, the last slide. There should be just a quick. Is this the last slide?
This is the last one.
Okay, so we'll give you at the end of the webinar just a few indications of how you can join our community through LinkedIn and Twitter, but also subscribing to the newsletter as well. So we'll be doing that later on. Okay, I suggest then that you start sharing Sabina's slide deck, and we start with Sabina with some really interesting insights into the threat landscape, but also some best practices. So let's have a listen to Sabina. Thank you, Sabina.
Hello, good morning. My name is Sabina Magalini, and I'm a surgeon, an old surgeon from the Policlinico Gemelli of Rome. And I want to talk to you about what we went through in these last months. We knew that the pandemic was coming from the end of January, but none of us working inside the hospital had an idea of what of a revolution the COVID-19 crisis would represent for our hospital structures. And consider that I'm speaking about Rome and not northern Italy, where you would have to multiply by at least a factor of 10 all the issues I am talking to you about, and I will illustrate to you now. Consider that the hospital ICT structures are tailored in a way that they can follow the surge and change of strategies of the realities they represent. Cybersecurity, as always, is another matter. This is my hospital, the Fondazione Policlinico Gemelli of Rome, Italy. The hospital is coordinating the PANACEA TDSO2 H2020 project on people-centric cybersecurity and healthcare. After 1.5 years of tightly scheduled project and definition of all our tools, on the 9th of March, Italy locked down for the COVID-19 pandemic, and a widespread hospital surge took place all over Italy. In Rome, they identified 5 COVID-19 hospital points, and the Policlinico Gemelli was the number 2, right after the Spallanzani Hospital. What did we do? What you see is the map of the major hospital, the one I showed you in the slide before. And close by, there's a clinic that is called the Columbus, which was completely empty, refurbished as a COVID-19 hospital, and activated in a time of 1 week. I did not evidentiate here the close by Courtyard Marriott Hotel. It's that little structure on the left with the green tent that was used as a discharge center for the COVID-19 patients, which could not go home and had to stay in quarantine. So we had over 100 intensive therapy beds over those that we have in the major hospital, and 250 normal ward beds inside the Columbus. And as you can see, this surge was impressive. Cybersecurity threats, Andrea, can you go to that side? Cybersecurity threats are well known, and they have already been addressed by our project. But when the COVID-19 came along, some of the pre-existing situations worsened. Basically, as a surgeon, an operator, I can say that we are usually too busy to take care of the cyber threats and specifically targeted to our realities. Maybe at home we're more careful, but in the hospital we're not so much. And in this case of the COVID-19 crisis, we were even more overworked than normal. And we were also using a lot of personal protective equipment, which makes it practically impossible to deal with the interface between the computer and the operator. So the cybersecurity behaviors were really relaxed. This is naturally, it's almost obvious that in surge and panic situation, all the usual threats there are made more insidious. So with the PANACEA project, we also asked ourselves, how can we mitigate these risks in view of a similar crisis? So these are the risks that are the main risks in our hospital and in our setting. And these are little examples of what has happened personally to us in this period. So the phishing that is usual in all hospitals, it is really something constant every day. There was a lot of phishing attempts with emails on coronavirus, with the buzzwords of this period. And this led also to malware with spyware and Trojans that were embedded in the interactive coronavirus maps. You have to consider that doctors, when they're looking for outside external information, they go on the World Health Organization map of the spread of the disease, or the regional map for the number of coronavirus cases. And there were a lot of domains with coronavirus, corona doctor / virus, COVID-19. And these maps that we usually visit have been defaced in many circumstances. Also, a problem that we had is the health administration, which is buying material. To do a surge, you have to buy a lot of things that you usually do not have in hospital, like a big quantity of surgical masks and protective equipment and drugs. And we have had cases of paid orders for equipment that never arrived. And so we lost also the money for this. And obviously it was not so obvious that these were fraud things. And also we had some scammers that can mimic the groups of the authorities, like Center for Disease and Control Prevention, or as I told you, the regional centers. So let's go on. These are the old vulnerabilities that had like an upgrading or a transformation. The new vulnerabilities that we identified in these settings were the first one on telemedicine, because many patients, chronic patients that usually come to the hospital, were kept at home, and so the doctors had the challenge to follow them there. And so we used some telemedicine applications that we had in the hospital, but these have a very low level of security. Naturally, what can go on there with the telemedicine consults is not so menacing, but anyway, it's the level of security is not there at all. The other big problem that we have was the monitoring of the infection data flows, because naturally when you're an authority, you want to know from the hospital or the hospitals in your region how the situation is going. So they are legacy systems in which you insert the data, let's say for infections that have to be used, maybe, I don't know, for TB or Zika virus or something else, and we use the same data fluxes for the COVID-19 systems. These systems got overwhelmed, and being legacy systems, the level of security have not been looked into now for the situation. Probably health authorities will build new systems now that are more secure, at least for this kind of infection. And the third problem, which we went through and we experienced it personally, is the fact of making all these new apps. These new apps are for many situations, for tracking patients, but also to follow patients at home. The Lazio region put up a very nice app, it's called Dr. COVID, to follow the patients at home. And it was, you could download it, but after 3 days it was already hacked, because the security controls were not so good. So they took it out for about a week, and then they reissued a new version that was better. So these were the new vulnerabilities that we saw. Can you go on with that? The other aspects we examined are that of smart working. You know, big hospitals have a lot of administrative people, and all these people were kept at home. So everything that could be done from home was done from home. Naturally, some of these are, they're used to using computers, but they were devoluted to a different function. So there was a level of technological illiteracy, of not being able to use, you know, these accesses. And especially on the VPNs, they usually exchange credentials. With the same credential, you open the VPN from the hospital and from home. And this, aside from the fact that it cancels your screen, but is something that is not so secure. The other aspect that we envisioned, but we didn't do anything to secure it better, is that the fact that in the temporary hospitals, we had to use the electronic health records of the main hospital. So there was a kind of overlap with the ICT system of the smaller hospital. This is when you decide to share your healthcare system, your healthcare record system. But otherwise, if you put up temporary structures like hotels, where the people are staying there, but there are medical patients, you're using the Wi-Fi systems of those structures, and these are not sure at all, and not secure at all. Also, we upgraded the staff because we hired a lot of young people to do, functions that were very important. And some of these are, the young people are digital natives, and they take cybersecurity for granted, and sometimes it's not so true. And the other aspect is that when you change the personnel from one function to another, you're changing practically the profiles. And there was a big problem of not deprovisioning these profiles. So we had a lot of open profiles of people that were not actually doing that work anymore. And this is seen as a security issue. So the staff shifting is, and the using of new staff is one problem that goes on with the surge. So what can you go on, Andrea, to the next one? Up. Okay. What can governments and the EU do for us? In the United States, where we look to see what happens, there have been numerous initiatives of the government that steps in to help hospitals, because I think they're even less cyber secure than we are here in Europe. So there has been a lot of intervention by federal or national cybersecurity agencies into the healthcare domain. Many of those started from giving more information from the government, saying, be aware of this, look out for this and that. So there is a push toward a better healthcare ecosystem. And also the governments are doing more cyber hygiene scanning. In Europe, naturally, we saw this thing a little bit later, but anyway, I'm sure that all the initiatives they are putting up are very focused to the problem. So there's been control on the tracing apps to support gradual lifting of the confinement measures. Guidelines for clinical trials in COVID patients have been issued. There is progress ongoing in the health-related aspect of the NIS directive, and there's a new newsletter that is coming out in the next month under preparation on these issues. In Greece, but I'm sure Kalia will talk more about this. For the remote working, they issued data privacy protection guidelines. In Italy, also the AIFA, which is a big organization that takes care of drugs, has issued guidelines for data protection. But basically, they're focused on data protection more than on cybersecurity. So this has, can you go on there? Next one. This has taken us to the level of saying, what can we do in the next half of our project? Which one of the emergency measures that we have put in place need a closer look from the security perspective? And which of these are here to stay? Because this is the real problem. So what are we going to look into the future for? And how the attackers have modified their approach to the current dynamics in healthcare, and what we have to look out for. This is important that it's constantly updated. And basically what we predict that the new normal is going to be. Here I give you just an outlook and of what our project is, but Matteo will focus on the issues. This is the way our toolkit is built with technical and non-technical tools, and those are the medical devices in healthcare organizations, and the information system life cycles are the objects of our project. Next, this also is a slide for you to keep, but Matteo will discuss this more deeply. I thank you very much for your attention and hope to have given you an overview of our situation in this last 2 months and now at the present. Thank you.
Thank you, Sabina, for your presentation. I have a question for you. How do you think that the hospital were able to cope with this COVID crisis from the cybersecurity point of view, especially in terms of governance. What do you think? What is your opinion and experience on this?
My experience of this is that actually we have not had much governments. Many of the systems we have are secure enough. Let's say the electronic health record system, which is a new one, is pretty much secure. But there were no alerts, nothing, no training. We just we managed to survive. Now we're having the aftermath of much information which has not been input into the system, so we are in danger of losing it. But when we use the system to the minimum requirements, we somehow managed with the crisis, but the problems of the aftermath are there.
Thank you, Sabina. Now I leave the floor to Kalia. Kalia, you have to unmute. Kalia, you are muted.
Yeah, no, she's coming in. Hello, Kalia. I think while you're just sharing your screen, I'd like to just say on behalf of all of us, a massive thank you to all of the frontline workers during COVID-19. My father has recently been in hospital. It's a very worrying situation in general. And I think that it's really important to recognize all the very hard work that people in the hospitals and other healthcare facilities are doing right now. So thank you. Over to you, Kalia, thanks.
Thanks a lot for the invitation. Hello to everyone. I'm Kalia Anastasopoulou. I'm coming from the 7th Healthcare Region of Crete, which is the tactician vector control and management public body of the Greek Minister of Health, responsible for the national health system in the region of Crete. I'm a senior researcher in data privacy and information security. And today we're going to talk about the IT healthcare readiness in the face of cyber risks in EU hospitals. 7th Healthcare Region is the only health region in Greece operating and integrating health information systems at a regional level. We have interconnected hospitals. The 7th Health Region is responsible for 8 hospitals, 18 health centers, 11 local health units, 135 GP offices, and 32 mental health units. It has high qualified and experienced staff in administrative, scientific, technical, and also in research terms. Next slide. Thank you. Is it COVID a surprise? COVID-19 a surprise? IT healthcare is not ready to face cyber risks in e-hospitals. There are high expectations, but limited tools from, as we can see from the EU mechanisms that deal with pandemic. In Europe, the financial crisis led many member states to impose and cut the healthcare expenses in almost every country. For instance, the OECD reports that the following that health investments per capita in Italy decreased until 2013, and only started to increase very slow after that. Healthcare organizations are not always considered as critical services. This is something that we face now with the COVID-19. As a result, low maturity on cybersecurity in e-health. For example, many hospitals do not have a SICO. Hospitals are easy targeted for malicious attackers. Lack of security awareness is another problem that we faced during the COVID-19. Lifespan of medical devices, for example, MRA machines can be outdated, and patch management process is not the first thing that they do for our hospitals. And most EU countries are wildly unprepared. This is what we can see from the OECD 19 report. Next, please. But what is digital health? Digital health describes the general use of ICT for health and is inclusive for both mHealth and eHealth services. As you can see from the scene, patients, healthcare professionals, healthcare organizations, and policymakers use different applications in order to find a way to communicate, especially during the COVID crisis, with a variety of applications that help them to facilitate the organization, medical follow-up of personnel with symptoms, monitor the enforcement to guarantee the infected persons from the EU recommendation, which is in April of 2020. As we can see, for example, patients use mobile apps for knowledge and adherence. They also use SMS technology to communicate with others during the COVID era. Also, there are healthcare professionals who want to make a decision, to have a decision support system and e-learning tools. They use telecommunication applications, and healthcare organizations and policymakers want, for example, to have predictive analytics and risk stratifications in order to prevent some issues during the COVID. Next. Here is an example how digital health interventions may address health system challenges implemented to ICT systems. Suppose that we have, during the COVID situations, we have insufficient supplies, commodities. So this is a challenge for the healthcare system. The digital health intervention here is that we have to notify stock levels of health commodities, and the application which is needed for this purpose, for this challenge, is logistics management information system. This is how a new system or can be produced from health system challenges during the COVID-19. Also, health management information systems and electronic medical records is part of lack of access to information or data. And the digital health intervention here is, for example, that data storage and aggregation are needed. So a system like that is the next step. Also, loss to follow-up clients lead to transmit targeted alerts and reminder to clients. This also can lead to electronic medical records. Next slide. But COVID-19 we can see it as an emerging risk. For example, COVID brings new risks. New risks and or increasing risks can be related to different areas of activities, such as new processes or new technologies. There are risks that will interrelate with processes, globalization, digitalization, and innovation. And all this brings together to new needs in order to produce new systems and new processes and new types of, for example, workplace or social organizational changes, something that we can see here. How hospitals are dealing with cybersecurity challenges. Many hospitals, for instance, add new medical devices to their networks. Many also open the field hospitals and testing sites. Other have new network infrastructure, which is being installed from a wireless access point, or they use telemedicine capacities. For example, they can just use an iPad and have access from everywhere and work during the COVID-19 from different hospitals, maybe, or working from home. And but all these situations is a big challenge for the COVID-19, because healthcare organizations are being targeted by ransomware attacks. They are not new trends in the industry, but the combination with the increased critical care needs will disrupt the operation of cyber attacks. Next slide. So we have to know which is our digital health ecosystem that we work on, and we are trying to implement new policies. E-health governance, which is related to national, regional, and global e-health coordination tool. Electronic health records, which is information of health and of every patient recorded in digital format. Standards and interoperability issues is something that is very important, with ISO standards that we're using for effective and accurate, for example, exchange and the use of data. Telehealth and telemedicines are tools and apps that we use during the COVID. Big data is also an unconventional. We need them because we need to make decisions in public health. Digital health literacy also are a set of skills, knowledge, and attitudes that a person needs in order to develop functionality. And then health, which is everywhere. We need, for example, our mobile phones and patient monitoring devices and other wireless devices in order to work in a hospital. So the IT healthcare cyber risks in hospitals are related to attacks against the telecommunication infrastructure. Email phishing is something that we usually face. Fake testing apps also, attacks against health organizations. And what are the actions related to these cyber risks? Data theft, financial fraud, password stealers, personal information theft, ransom, and disturbance are some actions that are related with cyber risks after a cyber attack. And the lessons learned from COVID are related to the transformation of health care sector, and also to the cybersecurity, which is now a priority. We understand that is a priority. COVID-19 has made us to understand the value of good health and the significance of healthcare sector. While the whole world is advised to stay at home, medical staff work day by day, and in order to treat those who are infected to the deadly virus. The need for centralized records is very important, and especially when they have to transfer from one medical institution to the other. Also, we must start digitalizing all the processes and record in order to be more efficient to medical staff. Also, security technologies are important in order to ensure a secure and robust environment, and COVID-19 has contributed to the emergence of the growth of e-doctor and e-pharmacy services that enable people to consult to a doctor or a pharmacist and get e-prescriptions. The Greek Ministry of Health is very close to this challenge. We have the e-prescriptions now, and also the National Patient Registry. These are the first baby steps that transform the health sector into the version. Cybersecurity is also a priority. We know now that we need a secure system in order to help our doctors to work in the way they have to. So phishing scams leading to the truth. So we have to be very careful with that. In the worst scenarios, ethical attackers target to the healthcare sector to exploit medical resources and deny access to the critical care systems. And also the center of attention to some hackers is related to the work from home, meeting conducted online, and online services and tools that narrow down the scope for hackers. The PANACEA project is a project which is related to cybersecurity policies for data and people, and the stakeholders are hospitals, healthcare devices and applications, policymakers and regulators, patient associations, and cybersecurity of privacy suppliers. Next page. Thanks for your attention.
Okay, thank you, Kalia. I leave the floor to Matteo.
Okay.
Please take consideration time. Matteo will give you an answer to the question how PANACEA can help. Please, Matteo.
Yeah, Andrea, can I share my screen, please? Thank you. Okay, you should be able to see my screen. Can someone confirm me?
Yes, we can, Matteo. Thank you very much. Mm-hmm.
Yes, I can.
Okay. So I will try to be brief, just to respect time. Matteo Merialdo, I work as a manager for the R&D security section within RIA Group, within PANACEA, and configured as the technical project manager. So I will try to give you an excursus of what we do in PANACEA and how what we do in PANACEA could help on a crisis situation like the one that we are sustaining, that we sustain within the COVID-19 pandemic. So the overall point related to PANACEA is that we are developing a suite of technological and organizational tools. So we are not developing a single system within the PANACEA project, we're developing a set of tools that combined are going to improve and to reduce the exposure to cyber attacks. And we are going to tackle both technology and people. And the overall idea behind PANACEA is that not a single tool can provide the overall improvement in the cybersecurity posture, but the combination of them, depending on the reality where they are deployed, can provide an improvement in this sense. In particular, in situation of crisis like this one that we just sustained. So PANACEA Toolkit is composed by 4 technological tools: dynamic risk assessment mitigation, secure information sharing, security by design and certification, identification authentication, and 3 organizational tools: training and education, resilience governance, and secure behavioral nudging. The main research concepts behind those 7 tools are related, for example, for the secure information sharing, are related to the sharing of healthcare information with a multi-tenant and cross-border system and federation of systems. Security by design and certification is taught mainly for medical device providers, but also for complex systems integrator, for example, and is going to be tied to the system engineering lifecycle and to the security by design over a system engineering lifecycle. Dynamic risk assessment and mitigation, we are working on a multidimensional threat modeling and attack modeling, response management, and vision analytics. For the identification authentication, we are working on biometrics and two-factor authentication, of course, keeping in mind that a system like that applied to the healthcare sector needs to be easy of use. We see that later. For the organizational tools, we are working on nudging, so secure behavior decision models based on nudging. We are working on tailored cybersecurity governance model for healthcare organization, which are going to be able to justify expenses and investments in the cybersecurity sector from a governance perspective. And we are also working on tailored, so sector-specific awareness programs for healthcare organization from nurses and doctors, but also for IT specialists. So very briefly, due to time, I'm going to explain a little bit better the technical tools, what they are about. So our dynamic risk management platform is going to manage the dynamic risk management that I was mentioning before, and the target is to protect the complex infrastructure. In reality, it could be applied without problems also to other critical infrastructure. We use the healthcare as a use case in this case, but our DRMP tool, as we call it, can be applied to other critical infrastructure. The overall concept is to monitor an environment, so a complex network, and to evaluate in a dynamic way the risk as a combination of the likelihood of a set of attack paths that we compute, and of course the impact due to the business, to the impact over the business. All is supported by visual analytics environment. Trying to be a little bit quick, we are trying to differentiate to similar solutions that exist in the market, because we are considering not only the network layer and the business layer, but also the access layer and the human layer. So we are trying to combine the information from those 4 layers in order to provide a risk evaluation that is really multidimensional. Sorry, I cannot, okay. It was blocked. So the idea is that the data collection from the network will not depend on the tool that we are using, for example, network scanner, vulnerability scanner, because we are adaptable to multiple different data sources. And also from a visualization perspective, we want to offer as much as possible to the IT specialists, in this case, a good visibility to how the network is structured in this moment. We are computing attack paths, which are not only technical attack paths based on the technical vulnerabilities, but also on what we call the human vulnerabilities. So, for example, the fact that a user could share credentials, could influence actions, and then it could use via an access to a machine, could use a machine and then allow an attacker to exploit vulnerabilities and follow the path. So that part is quite innovative, and we are already at the good stage of development. All the models are ready, and we are implementing it with a set of quite complex use cases. Based on the multidimensional attack graph, we are computing the risk, using also, of course, the business layer, the business impact, and we are suggesting mitigation actions which are prioritized, and they are not only technical mitigation action like patching, firewall rules changing, and so forth, but also aim at, for example, suggesting a set of nudges for the healthcare personnel, or organizational structure changes, or governance changes, and so forth. So it's try to be quite comprehensive. I was mentioning before the secure information sharing. So the overall concept is to develop a system that allow a secure information sharing among a federation of tenants of healthcare information. So the overall concept and the requirements that we got from the end users is that such a system should be fully distributed, completely cross-border, in order to be able to work on different countries, which is one of the most important use cases, to be able to transfer information from one country to the other in case a patient has an accident in a remote country and they need the hospital, local hospital need to retrieve in real time or as fast as possible the data, the healthcare records of the data. Of course, it needs to be completely multi-tenant and multi-organization. So we developed this tool, which is completely distributed, and we are quite a good stage of development, to be honest. The overall TRL will be probably higher than 6, which should be the minimum. Fully GDPR compliant, and the overall concept is really to be able to share information, also big files, so for example, images and so forth. As a possible evolution that we see for the secure information sharing platform is the fact that, in fact, it could be used as we could leverage on the knowledge base of the security information platform to correlate the warnings and then to be able to extract, for example, how a virus could spread and detect anomalies and make predictions and so forth in the optic of what could it be an early warning system for healthcare. So there are a lot of similar concepts related to that in the cybersecurity world. We are trying to apply a similar concept also to the healthcare world, using at the end similar technologies, but now specialized for the healthcare world. Then we are working on security by design, and Sabina was mentioning that a fast development of an application during a pandemic in order to provide a service could lead to cybersecurity vulnerabilities. In reality, cybersecurity vulnerabilities are quite common in medical devices or medical systems due to a general lack of security by design good practices. So we decided to develop a framework, a security by design framework within PANACEA, which is mainly composed by 2 tools, the Secure Design Support Platform and the Compliance Support Tool. The Secure Design Support Platform, what it does is basically performs a set of iterations of risk assessment over a system in development, a medical device, for example, in order to provide suggestions able to reduce the level of risk of a system from the preliminary phase to the testing phase, if we imagine a normal waterfall-like structure. The compliance support tool is going to provide the support for the compliance part, so the compliance to standards, in this case, healthcare standards. Those are 2 tools, so they are integrated, they are connected, and you can see a couple of images. So we are quite advanced also with this, and we will finish at the end of the year with quite a decently high TRL, despite being a research project. The last tool that I'm talking about, which more than a tool is a technology that we are developing, is related to identity management. So usually it's based on login password authentication, 1-factor, also for medical devices. We want to overcome this limitation, and also to overcome the fact that very often, and especially in a period of crisis, passwords are shared, they are put on post-it, even for medical devices. So basically we developed a tool which aim is to be easy of use, secure, so at least a 2-factor authentication, very affordable, and extremely easy to be integrated into existing IT infrastructure. So we develop an application which takes the biometric data, in this case an image of the face of the person, and records a token which is shared with a repository within the healthcare organization. And then simply using the Bluetooth, which needs to be activated, of course. It's simple. It's the person, the healthcare personnel person, just needs to come close to a medical device, for example, or a system used in the hospital, and then activate the webcam and being recognized in order to access to the system. In this way, we can limit the amount of interactions, and we can still have a much more secure system. Nowadays, we are working on improving the recognition part of the biometric by using, even if the person is using masks, because it's quite a use case, quite common in this period. We are also quite advanced on that. Of course, it's a technology more than a tool in itself, but we are going to apply to several use cases during the next year. And I'm done. I try to be as quick as possible, Stephanie. I hope it's been sufficiently fast.
You've been very fast. You've been great. Thanks very much, Matteo. Right, I think that we have a few questions for our panelists, but due to the time, I would suggest, Andrea, that we launch the final poll quickly, and then we move into the interactive session. So we're ready to do that? Okay, super. So the final question is, and maybe you've got some insights from this webinar, how can we improve cybersecurity in healthcare? Is it through more investments in staff training? Is it by improving risk management and response to threats? Or could it be through approaches designed for people, processes, and not just the technology? So please reply by answering the best way you think we could improve cybersecurity. And Andrea will keep us, will tell us how many people are responding, or the percentage of participants, so that we can.
So yes, Steph.
Yeah.
Yeah. So half of our attendees believe that the way to improve cybersecurity in healthcare sector is through improving the risk management and response to threats.
Well, that's not surprising based on our question earlier, is it? No. Okay.
We also an highest 35% of people thinking that it has to be done through approach designed for people and processes, so not just by improving technology.
Okay.
So they are online with our main purpose, that is to bring a people-centric approach to cybersecurity in healthcare. So this is a very nice information that
I think so. Yeah, thanks everybody for voting. I think we can close the poll now, Andrea, and move on to the interactive discussion. So we have a few questions. Pasquale, you ready? And you remember?
Yes.
Yeah. Yes. So I'll leave the floor to Pasquale, and who has a small announcement to make as well at the end of the webinar. Okay, the floor is yours, Pasquale. Thank you very much.
Yes, okay. We have a question for Matteo. Before reading this question for Matteo, I want to highlight to everyone that the toolkit also contains an important governance solution set part. And we have developed it, and we have designed a general model for managing to do governance in the hospitals. If you go on the website, you will find details on this. And however, keep in touch with us, and we will explain more on this. The question for Matteo is about the DRMP. Is there a current proof of concept deployment of DRMP? It seems to be quite a complex undertaking.
Well, yeah, there is
curiosity here is to understand which state are we, Matteo.
Yeah, Pasquale, you're a bit disturbed your communication, but in any case, definitely is much more than a proof of concept. Keep in mind that the development of DRMP is using a part of work that we already did. Some of the partners of PANACEA within an FP7 project, Framework Program 7 project. So we could be able to reuse at least part of this work, especially with what regards a concept like reachability metrics and the data graph. And we reused it and we added all the part related to the access and the human layer. So nowadays we have not an integrated system yet. It will be the first version integrated will be around October, but at the end of the year, we will reach definitely technological readiness level 6. Actually, we are testing it with a cyber range that is being provided by Gemelli and my company, RIA, with around 50 or 60 nodes. And so multiple vulnerabilities, some kind of a complexity on the network, firewall rules, and so forth, but also the human layer, it's already imported because the cyber range is emulating a blood sample analysis laboratory with all the logics of the people working there, their accesses to the machines, and so forth. So definitely, we are going to do a workshop and a presentation of the tools, I think, towards the end of September, and we will be able to show what we did up to that moment. But for the end of the year, we will have something much more than a proof of concept likely. We want to demonstrate the tool with at least 1,000 nodes of the network, so you can imagine that it will be quite decently engineered, let's say.
Okay, thank you, Matteo. And I want to highlight what Matteo said about the workshop that we will do in September. And we will keep you informed on this workshop because we would like to get your feedback on our tools. So in that case, we will do a virtual meetings where we will show the solutions at the stage where they will be. It will be quite advanced. And you can take part. So we will invite you. So let's stay in touch on this. It will happen second part of September this year. I think we have no more time. We will answer the other questions on the Q&A via email. And I leave the floor to Stephanie for the closing words.
Yeah, so thanks very much, Pasquale and everybody. Thank you for the great insights and this really first-hand experiences on cybersecurity in healthcare in general, not only during COVID, but I think COVID has brought to light, it really has brought into the open the very serious challenges that we are facing in the sector. I think a lasting message from my side would be that cybersecurity is ultimately about the safety of patients and their well-being, because if we lose their data, then their personal information and their credit card information could be stolen, and that could be a fraud issue. And nobody who is unwell wants to have extra stress from the impacts of a cyber attack. But also when we look at the medical devices and other equipment that's used that may be vulnerable, where if we're not safe, if we're not secure, we're not safe. So if we're not safe, the machines aren't safe, the staff aren't safe, and neither are the patients. So I think and I would pick up on Pasquale's invitation. We'll send you more information about the workshop in the second half of September. It will be a virtual event to ensure the continued safety of participants. But we do really call on you and any other colleagues you have or interested parties to come along and join PANACEA and help us validate the tools that we're developing. So that's a final invitation. Just a reminder that the results from the polls, the recording and the presentations will all be made available online, and we will let you know when that happens. And to say a final thank you then again to everyone for joining today. Stay safe. We're not out of COVID yet. So please take extra care as well, everybody. Thank you for joining. Thank you also to participants for joining outside Europe. It's also for them as well, not just for Europe. So thank you as well. So with that, I think, thanks a lot, everybody. Just a quick goodbye from the panelists.
Bye-bye.
Bye. Bye. Thank you, Sabina. Talia, thank you. Bye. Bye. Good. Thank you for all the work that you're doing. Okay. Thanks. Thank you, Andrea, as well, for being our man, coordinating all the activities. And thank you very much, Pasquale, for co-chairing this morning. Not this afternoon, because it's 12:04. We did it on time. Thanks again. All right. Bye for now. And we'll be back, obviously, with more webinars in the future. So stay tuned on that as well. Okay. Thanks a lot. Bye.
Bye-bye.